Final review, lecture 3, international comparisons of healthcare system. In the previous lecture, you learned about the performance of United States providers, healthcare providers, such as pharmaceutical companies and hospital and physicians and healthcare insurance companies. But to compare the overall performance of the United States healthcare system, we have to make an international comparisons, and also the three-leg stool of medicine can be used as a rubric to compare healthcare system across countries. So we use triple aim, cost, quality, and access to make international comparisons among the developed countries with the United States. A good question here would be, in a short but well-structured essay, compare the United States healthcare system to the healthcare system in one of the following countries: Germany, Canada, or United Kingdom. Now, in your essay, you have to consider basically compare this, use these three index: access, quality, and cost. And in your conclusion about which system basically is preferable, you have to consider the strengths of each country and weaknesses of each of the country you selected to compare to the United States. Now, this is actually again a review of what you had in chapter 4. There are 5 main global healthcare models in terms of access. The first one is the National Health Services, which is a public contracting system. A good example would be in England. So basically, all the providers are public contracting system, so the second type is a single payer system, is a national health insurance model. The best example would be in Canada. That is a universal health care plan, and everybody has to basically use the universal health care plan for hospital and outpatient. There's no way to buy out of the system, unlike the UK. The employment-based insurance is an insurance model in Germany, and the private insurance model, the best example would be in the United States. The out-of-pocket model also is the best example within in the United States and in developing countries. Now, based on the triple aim, performance of the United States actually ranked 50 out of 55 countries. But you have to be careful when you're comparing cross-country comparisons. The data from different countries may not be directly comparable. There's no standard taxonomy to basically to compare across the countries, and it's difficult to draw a line separating the medical services. That's another problem, and there is a measurement error basically. So this is the limitations of the other studies in international comparisons. Now, before I let you know about the limitation before going through the results of the empirical studies from the other studies. United Kingdom has a tax-funded model. The financing is the public primary funded with taxes, and there is a limited co-pays. The private, but it's a public contract, so it means that there are the providers are private, but they are basically contracted by public. The delivery is like, for example, is a universal coverage, although there is an option of buying out of the system. About 10% of the people, they have their own health insurance, private health insurance. The general practitioners contracted by NHS, the outpatient specialists are also NHS employees, and the hospital are mostly public, and there are some private as well. Now, the regulations, legislative bodies set the rules, the Parliament, the Secretary of the State for Health, and the Department of Health. The regulatory authority of the NHS in England basically set the rules. The second type of the main model is the employment-based insurance model. Mainly, the good example would be in Germany. The name of the healthcare system is the statutory and private health insurance. The financing covered by taxes, and there is a minimal copays, and the privately bought basically insurance, which is the price based on the risk factors. Now, the delivery is a general practitioners and specialists. They have their private practices, and they basically charge fee for services. The hospitals are state owned, non-profit private, and for-profit private. The regulations is based on the government mandates, health insurance, and allocate the funds, but leaves the private group to coordinate the care. The fourth types of the healthcare model is the national health insurance model. The name is Medicare in Canada. Is a single payer via provincial general tax revenue, and the federal government provides funds through Canada Health Transfer. There is no copay for public services, and so there is 67% have private insurance. This private insurance is only for secondary care, such as basically dental and mental care. There is no option of having private health insurance for hospital and primary care doctor and a specialist. Everybody has to basically be covered by the universal health plan, and the waiting lines, it's basically long for the hospitals. So even if you have money, you can't buy basically private health insurance for primary doctor or hospital or a specialist. The delivery is universal coverage organized by territory provinces, and the hospital, the providers, primary care and specialists, they have their private practices, and so the hospitals, there are public and private, but there are predominantly non-for-profit, and they're varies by provinces. The regulations is the provinces, the primary jurisdiction ministry basically set the rules, and in the national level, Health Canada set the rules. Now, this is actually the table from your chapter 16 in your textbook, Santur and Noon, which shows the triple aim among 7 developed countries, and comparing the cost, quality of care and access. And as you know, United States has the highest healthcare spending per capita, about 8,000 compared to the other countries, basically developed countries, more than 3,000 differences per capita we are spending. In terms of the quality, we can say that, for example, the percent satisfied with healthcare system in 2008 shows that in the United States, about 83% they were happy with this high, large, basically expenditure. Only we have 83% compared to the other countries. They have even higher percentage of the satisfied patient with the low spending on their healthcare costs. Um, in the access, as we know, United States has the highest percentage of the people without insurance compared to the other developed countries. The average spending on health per capita in the United States is increasing compared to the other countries in terms of purchasing power parity and as a percentage of the GDP both. In terms of the healthcare expenditure per capita by source of funding, adjusted for differences in cost of living, still United States has the highest healthcare expenditure per capita compared to the other developed countries. In terms of quality of care, United States has the basically lowest number of the people satisfied with the healthcare system compared to the other developed countries. While they are spending less in their healthcare system, still people are happier than and satisfied with the healthcare system than compared to our people in the United States. In terms of quality of care, again, healthcare-related avoidable mortality per 100,000 in the United States is higher than the other countries, basically. Now, the United States spends more on medical care in absolute and relative terms than do the other countries. So where we do actually spend our money, we have more MRI and second highest number of the CT scanner per million population. And this is basically in the United States, we have greater availability of cost-enhancing medical technology. Costs, which basically increase the healthcare expenditure. There are two types of medical technology. The first type is cost-saving technology, and the second type is a cost-enhancing medical technology. Cost-saving medical technology means that the cost of new technology is lower than the old technology. It's basically is more cost-effective to use the new technology than the old technology. But the cost-enhancing technology means that it's not actually the cost is not lower than the available technology. So we have, new technology that they are even not more cost effective than the older available technology. So those are the reason we have higher healthcare expenditure than the other developed countries. So the lifestyle and environment, basically in the United States, we have the highest rate of obesity. The median alcohol consumption is higher than the other developed countries, and the pollutions are basically, in terms of per capita nitrogen oxide emissions, are higher than the other developed countries. The availability of the medical resources does not explain the high healthcare costs in the United States. The United States has the highest infant mortality rate, death per 1,000 live births, and compared to the other countries, nearly universal health insurance coverage. The government responsible for well over 75% of healthcare spending in the other countries, while in the United States, government basically accounts for 60% of the whole healthcare spending. Very close, but the patient satisfaction in the other countries are higher than the United States. In terms of triple aim, in summary, for example, let's compare the United States with Switzerland and Norway. The United States per capita cost is about 9,000 compared to the Switzerland, which also it has a high cost, but but is still lower than the United States, 6,000, and Norway is about 6,000. Um, the the percentage per GDP, still United States has the highest percentage of the healthcare cost per GDP. As a percentage of the GDP, the obesity rate in the United States is about 35% compared to the Switzerland by 10%, and in Norway also 10%. Their life expectancy in the United States is 79 compared to the Switzerland with 83 and Norway with 82. Now, in summary, based on the triple aim, performance of the United States is not good in terms of access. We have uneven and on average low given no universal system of the health insurance. There are several dimensions of access, and basically the cost is the biggest problem for access to the care, and the access problem faced by uninsured. The quality on average, we have poor quality that can be defined based on the structure, process, and outcomes. The cost escalating, healthcare costs with high growth rate over the time. Now we come back to this question that we had at the beginning of the lecture. So what is the best, healthcare basically economy model? So your answer could be varied, but this is my answer. In terms of the three essential and deeply intertwined ingredients, which are critical to our healthcare system in terms of financing, delivery, and regulation, who pays to whom and how they pay, how much they pay, and what they pay for. In the United States, we know that the healthcare is financed or paid for in a variety of ways. And we are comparing the United States financing, delivery, and regulation with another country like Canada. In Canada, the financing is a public finance is 70% and private finance is 30% for drugs, dental, and optometrics. So the 70% is for the primary medical care such as outpatient, inpatient, and the 30% are the basically from private insurance for drugs, dental, and optometrics. Now, the financing is from the income taxes. There is no deductible. There is no co-payment for the main primary basically care and hospital and outpatients. For the private insurance through their also for private insurance, the people they have either through their jobs. But it's not permitted, of course, for basic hospital and medical services. So these private insurance are for these basically expenditure, drugs, dental, and optometrics. The delivery is public funding, but private delivery, and the private and public providers, including hospital, physician, nurses, technicians, etc. The regulations are basically set by the federal government, set the rules, and the provincial governments adjust based on their geographies and population needs. Now, which one do you prefer? You can actually decide. Now, let's go back to the first question we had. So, you are actually hired as a general surgeon to to outline the proposal for national health insurance. And as a part of your proposal, you have to discuss these factors. No, there is no single basically answer to this question, but this would be just briefly my answer. For the beneficiary and benefits package, I prefer a universal health care to assure delivery of basic health services free of charge or at a subsidized fee. Definitely, I prefer some fee to avoid moral hazard to entire population. For the financing, similar to Canada, everyone can pay for basic health insurance, basic health care via health tax as a percentage of their income. The benefit package could be similar to the Affordable Care Act, should include the preventive care and essential benefit with the addition to dental care integrated into medical insurance instead of being a separate plan. The reimbursement could be through the fixed and flexible basically payment, and the payment in terms of capitation, weighted capitation, and fee for services. The delivery for physicians could be physician referral procedures by federally funded and non-profit funded healthcare system. The regulation, similar to the Medicaid, the federal government should set the minimum standard of care. However, a state would have the flexibility to expand the minimum to suit their state's people. So, but the private sector competition assures most cost-effective medical care. This is basically what I prefer. Again, there is no simple answer for this question. This is the end of a final review.